Uh, this case actually doesn't belong to me. It's given to me by another consultant whom I will acknowledge later. But it's a very interesting case, and I thought we can all learn from this case. I'm going to present the history, physical examination, and findings stage by stage. And Kashmira will try to answer questions just like we do in an exam. And the idea is to see how we arrive at a diagnosis. We don't arrive at a diagnosis in one jump. We always go step by step. And that's the process which we have to learn. Okay, everybody ready? Here we go. We have a 4-year-old boy who came with diminished appetite and intermittent vomiting. And for the last 2 months, he has also been having intermittent, he has been having exertional dyspnea with functional class 2. So details of present illness. He developed decreased appetite for last 2 months, nauseous, frequent vomiting, intermittent, breathless on playing games and running, no limitation in routine activities, and no PNT or orthopnea. Parents noticed that his lips are looking darker for the last 5 months. However, a lot of other cardiac complaints were negative, particularly chest pain, syncope, pedal edema, no respiratory symptoms, abdominal symptoms, urinary symptoms, or neurological symptoms. Past history, he had a history of atopic dermatitis from 7 months of age. He was also told to have eosinophilia at the age of 7 months and approximately 10% eosinophil counts. No history of bronchial asthma. He was started on diuretics, furosemide and aldactone for the past 1 week and says he is somewhat better, slightly better. He was also told that he has hypothyroidism for the past 1 week and he's just been started on 12.5 micrograms of L-troxin. He is normally developed and immunized. Largely normal prenatal, natal, and postnatal history. His mother is 28 years. His mother's maternal cousin died at the age of 3 years with query heart disease. We do not know any detail, but the child definitely had hepatic dysfunction with jaundice and no COVID in the family in recent times. Systemic questioning, most of them were negative. They're all listed here. I'm not going to read out all of them. All systemic questions were asked, and apart from the one I described in earlier slide, most of them were negative. So that in short is the history, okay? So Kashmira, you have to start. What does the history suggest to you?
Sir, history of dyspnea and exertion along with cyanosis. Possibility of cyanotic congenital heart disease.
Okay.
And there is history of decreased appetite with vomiting, nausea and vomiting. And
he is 4 years old and his symptoms are only for last 2 months. And they said darkening of lips. Okay. So you think cyanotic heart disease is a strong possibility? Cyanosis appears at the age of 4 years?
No, sir, won't appear.
Yes, cyanosis can appear later on in life, but 4 years and that too only for 2 months is not a, or 5 months is not a great thing. So think again, what does the history tell you? He's got dyspnea, he's got poor appetite, he's nauseated. Okay, let me help you. First thing is it's a short history. Although he's 4 years old, the symptoms don't last. So first of all, it's whatever it is, it's not an acute illness, but it's definitely not a chronic illness. It's a subacute presentation. Illness we don't know, but it's a subacute presentation, recent onset. Now, presence of heart failure is very, very likely, isn't it? He has exertional dyspnea, he has abdominal discomfort, he has poor appetite. These are classical signs of heart failure in a child, isn't it? Poor appetite, less intake, nauseated, and exertional dyspnea. Wouldn't you say You're presenting a cardiology case discussion. You will say that there is a recent onset or recent presentation of heart failure.
Yes, sir.
That is what comes to your mind first, isn't it?
Yes, sir.
So to me, this history suggests classical symptoms. And he also told you that he took diuretics and he felt better.
Yes, sir.
So what more do you want for heart failure? So I
Yes, sir.
think the history tells us that probably he has heart failure has such symptoms slightly related to diuretic. Okay, let's
Yes, sir.
proceed now. That is problem. So the way we arrive at a diagnosis is always at every step we describe the problem in our mind. So this is problem description number one is that this 4-year-old has recent presentation with heart failure. Okay, right. Let's go on.
Yes, sir.
Now, other points should be kept in mind from the history. We cannot ignore other parts of the history. He also said some atopic dermatitis. He had some eosinophilia. He had no asthma. Somebody told him he has got mild hypothyroidism. Uh, Nothing significant in the family history, but one maternal cousin at mother's side, somebody died in childhood, may or may not be related. But we will keep this at the back of our mind. But what is in front of us is heart failure. Okay?
Yes, sir.
Right. Let's go on to physical examination. He weighs 15 kilograms. He has syndactyly, left foot. His lips are pigmented. Even no cyanosis, it's pigmented. No
Mm.
rashes, no pallor, tachycardia, BP of 90/60, normal saturations in all four limbs. His pulse was normal and his JVP was elevated. Okay.
Yes, sir.
Shall I go on to the next slide?
Yes, sir.
Hmm. Cardiovascular system examination. The apical impulse is in the fifth left intercostal space in the medial to the mid-clavicular line. It did not have any special character. I would call it a normal apical impulse. On cardiac palpation, there was no specific finding. On auscultation, his first heart sound appeared to be normal. Second heart sound was split. The pulmonary component of the second heart sound was loud. There was no third heart sound, there was no fourth heart sound, and there was no murmur. Okay. That
Yes.
in short is the fine. I'm not going into great detail of examination because I need more time for the whole discussion. Okay. So in a sense, that is what is the cardiac findings. If you have any questions on cardiac findings, you're welcome to ask me. Okay. Respiratory system essentially was normal. Do you want any more information on cardiac examination?
Mm. No, sir.
No. Okay. Abdomen, liver was enlarged, tender, non-tender, sorry, non-pulsatile. There was no splenomegaly. Central nervous system was essentially normal. Okay, that in short is the examination. Now, I want you to identify the important points in examination and tell me what does the examination indicate. I'll go back to cardiac findings if you want. General examination findings are here. Apart from hyperpigmented lips, his appearance was essentially normal. He had tachycardia, PP of 90/60, elevated JVP. Cardiovascular examination are listed here. Now tell
Yes.
me what are the relevant points in physical examination and tell me what is your conclusion.
The child is having tachycardia, along
Okay.
with BP is maintained.
Mm-hmm.
And JVP is raised.
Mm.
So that it suggests again right-sided heart failure.
Okay.
And on cardiovascular examination, the apex beat is in normal position, normal character. So there is no cardiomegaly.
Mm-hmm.
S1 is normal, and P2 is loud, which suggests of pulmonary hypertension, possibility
Okay.
of pulmonary, and no murmurs. So
Mm-hmm.
no shunt shunt murmur across the valves. So no shunt lesions could
Okay.
be.
So you are sitting in the outpatient department now. Now you have to make a provisional diagnosis. Remember, I told you at each stage you have to make a impression. I gave you the first clinical impression on history. I said it was heart failure. Now you have to make the second level of conclusion. Mild parasternal heave, Dr. Smith. Yes, consistent with some degree of pulmonary hypertension. Yes. So now, what is your conclusion from history? So you have to no, you have to at every stage you have to think back history and first history, then history plus examination, then history plus examination plus ECG, history plus examination plus ECG plus X-ray, then history, examination, history, ECG, X-ray, echo. That's the way you go. So now what is your conclusion?
So the child is 3 years old and he has a subacute history of heart failure.
Okay.
And cardiac examination is suggestive of pulmonary artery hypertension along with right-sided heart failure. And
So you have to make a provisional diagnosis now.
This is a case of pulmonary hypertension with heart failure, right heart failure, and the cause of hypertension can be any pulmonary cause can also be there, as the child has eosinophilia and.
See, if you remember, and now what is the most prominent part of the whole presentation? The most presentation that came with the symptoms is and his physical examination seems to be the heart failure part. Okay.
Yes, sir.
It's not the pulmonary hyper. I said what apart from accentuated P2, did I say anything else? Did I mention tricuspid incompetence? I didn't even mention right ventricular heave until somebody asked for me. So, so let's the way I would point the points of interest in this exam would be, I would say poor weight gain is important, no edema, JVP is elevated, evidence of heart failure, that is tachycardia, hepatomegaly, and JVP. But the most important finding I find is a patient is in heart failure, but there is no cardiomegaly.
Yes, sir.
You know, all heart diseases which causes heart failure generally produce significant cardiomegaly. You agree?
Yes, sir.
They almost always produce abnormal cardiac pulsations. Either it produces increased left ventricular pulsations or increased right ventricular pulsation or not. Okay. Here there was some mild right ventricular heave, but then in a thin child you never know it is normal or it is a significant right ventricular heave. I'm not sure. That's why I didn't mention it. So here the way I would look at it is, here we have a patient who's significant heart failure enough to make him present to hospital and need 2 diuretics, but at the same time his heart size is not enlarged. That's very, very interesting for me. Okay.
Yes, sir.
Right. So how would you approach this? What would be your next approach?
Sir, and chest X-ray.
No, not investigation. Baba, you have to
Okay.
give some work to your brain.
Yes, sir.
So you have to describe problem number 2. Problem number 1 was heart failure. Problem number 2 at the end of examination was it is a heart failure with a normal heart size. Yes, possible PAH, but the heart sounds are normal. The first heart sound look normal. There are absolutely no murmur. So we have to think of some cause of heart failure now. Okay, what can be the cause of heart failure? So we have to the way to put that is put up a list of causes of heart failure in a 4-year-old child. Now I take this from one of publications. So these are the common cause of heart failure in a 4-year-old child: structural heart disease, child with no structural heart disease, and non-cardiac causes of heart failure. Okay.
Yes, sir.
Now, from your physical examination, you can straight away rule out structural heart disease, isn't it?
Yes, sir.
Yes. No history of congenital heart disease, no physical signs of congenital heart disease, no sign of rheumatic heart disease, no murmurs, no nothing. Straight away, you can rule out a valvular or some sort of structural defect in the heart. Agreed?
Yes, sir.
Okay. At least physical examination doesn't suggest any non-cardiac causes. No, he didn't give any history of sepsis. He didn't look anemic. There's no history of hypoglycemia. No obvious endocrine disorders. There's no evidence of AV fistula or runoff. There's no other systemic disorders. Now, hypothyroidism, I agree. Somebody told him he's hypothyroidism. We'll keep that in mind. clinically in a child, mild hypothyroidism is not easy to make out clinically. We'll keep that in mind. But at the moment, non-cardiac causes that do not appear to be a big importance. So that leaves us with no obvious structural heart disease with heart failure. This list of causes. You agree?
Yes, sir.
Now we have to go down this list one by one. Can it be myocarditis? No, I can rule out arrhythmia because no arrhythmia was ever
Yeah.
noted. And no
Yes, sir.
hypertension was ever noted, was seen by doctors. Myocarditis is possible, but then we had no cardiac enlargement. First heart sound is normal. Usually myocarditis causes soft first heart sound, no gallop, no murmurs. The same applies to dilated cardiomyopathy, which is probably more common than myocarditis. Restrictive cardiomyopathy is a possible cause, and that's one cause of heart failure, which does not cause the heart to enlarge much, or it may cause enlargement but very mild degree. The restrictive cardiomyopathy you have to keep in mind. Constrictive pericarditis is possible. They're uncommon, both are uncommon causes, but both these can present with heart failure with relatively normal heart size, right?
Yes, sir.
When I say relatively normal heart size, what I mean is heart size not commensurate with the degree of symptoms. You can have mild cardiomegaly, that's no problem. You can't say that that one little enlargement is against heart failure, but then coronary artery disease, rare in a 4-year-old child. I mean, you do have coronary problems, but it's a very, very uncommon presentation, and that would be the last uh, condition which I would keep in mind. So at the moment, heart failure with no structural heart disease seems to be possible. This dilated conditions looks unlikely. I would keep in mind this normal heart size heart failure condition. Okay.
Yes, sir.
Coronary would be a condition to be excluded. I don't think I'm seriously considering it. Would you consider that reasonable?
Yes, sir.
Okay. Okay. Now read the ECG for me.
Standard
Hmm.
12 lead ECG, and heart rate is around 100 per minute. Sinus rhythm,
Yes.
tall P waves, suggestive of right atrial enlargement.
Very good.
Narrow complex QRS. PR interval
Yes.
is normal.
Okay.
And axis is
Normal. Upright
normal
in
axis.
one,
Yes. Yes,
upright
sir.
in one and upright in
Right
three.
in
AVF.
yes, sir. There's a on there's a R dash R pattern fragment QRS in V1.
Possible, but I think that's the R wave from V2 overlapping it.
Okay, sir. So predominantly right ventricular forces in V1 and sorry,
No,
left ventricular forces.
left ventricular.
Left ventricular forces. Sorry. So there's
Yes,
an
agreed.
overlap.
Yes, I agreed. You've done well. So to summarize, would you consider this ECG normal or abnormal?
Tall P waves are there, and
So give me a ECG diagnosis. Report this ECG like consultant.
Sinus rhythm with tachycardia with sinus rhythm with right atrial enlargement with predominantly LV forces.
Okay. So it's an abnormal ECG.
Yes, sir.
So that's the first point. The ECG is not normal. Secondly, it's a right enlargement. So the right atrial, no, whenever there is heart failure, you always look for right atrial enlargement and left atrial enlargement. The left atrial enlargement is not obvious, but right atrial enlargement seems to be present. But the left ventricular voltages seem to be prominent, like deep S wave in V1, V2, relatively tall R wave in V6. But otherwise, the QRS and PR and axis and everyone, the ST segment seems to be non-specific T inversions in standard lead 1 and limb lead AVL and also V5 and V6, which are not diagnostic, but overall it's an abnormal ECG. Okay.
Yes, sir.
So now does it lead you anywhere? ECG cannot make a diagnosis, I know, but does it lead you? Because initially you said it was possibly pulmonary hypertension. So
Yes,
it's a
sir.
question of whether it's a right-sided disease or it's a left-sided disease or it's a biventricular disease, or two-sided disease. What would you say?
There's predominantly LV forces are there, and
Mhm.
so possibilities there of left-sided by and
Got it. Yeah. So
RA is also there.
yes, that's what the ECG contributes to us. See, first of all, we had some doubt whether it may be a disease affecting only the right side, but now it seems that yes, probably it's a disease affecting both right and left side. And I wouldn't be surprised if the right-sided disease is secondary to the left-sided disease, or maybe the disease affecting both sides of the heart. Right? Agreed?
Yes, sir. Yes, sir.
Now, look, I'm giving you some of the answers not because I'm not asking you questions like in an examination. I'm just trying to teach you how we approach a case in a real life situation. Okay,
Yes, sir.
that is a how step by step. So the next step is the X-ray. Go on.
It is a chest X-ray PA view, well centralized,
Hmm.
uh, good exposure. CT ratio is around 0.55.
Mhm.
Uh, it is a LV type of apex,
Mhm.
and uh, there is right atrial enlargement,
Okay.
and lung fields are there is a pulmonary venous congestion, cephalization is seen,
Okay.
and the carina also seems to be widened, carinal angle.
Mhm. So,
So
one
suggestive.
thing I would suggest, you're doing good, but then, you should have a systematic way of presentation. It shouldn't go back and forth, back and forth.
Yes, sir.
So, for example, you shouldn't go to pulmonary vasculature and then come back to atrium and then go to LV apex and then come back to right atrium. That's not
Yes,
the way.
sir. Yes, sir.
CTR, your bony cage, situs, whatever you finish, and then
Mm.
you talk about the chambers and then go to the pulmonary vein, pulmonary artery branches, pulmonary vein, and then aorta. That's the way you go systematic. Then you won't miss any. So I
Yes,
agree.
sir.
Normal CTR, right atrial enlargement. You said maybe left atrial enlargement, and then main pulmonary artery, pulmonary artery segment
Yes,
straightened up.
yes, sir.
And then you said upper lobe veins prominent and then gone.
And left LV type of apex, sir.
LB type of apex, then gone. Anything else?
Uh, yes,
You see, you yourself said that he is in biventricular failure, isn't it? Possibly.
yes, sir. Mm.
So, what was the evidence of left ventricular failure? You have to look for pulmonary venous hypertension in various degrees. One is
Yes,
upper
sir.
lobe veins. Any other sign of pulmonary venous hypertension? Don't you
Curly
see
line.
curly lines? Are they present?
Uh,
Even before curly lines,
yeah,
something else is very obvious. No? Don't you see both the hilar regions are hazy?
sir. Yes, sir.
Yeah?
Yeah. Yes,
Okay.
sir.
Don't you see the interlobar line on the right side? Unfortunately I don't know whether you'll be able to see my arrow. Do you see my arrow?
Yes, sir. We can see her.
Okay. Can you see the interlobar fissure here?
Yes,
Huh?
sir. Yes, sir.
Okay. And if you look carefully, can you see some horizontal lines? I don't know whether from your side can you look carefully here? You're seeing some horizontal lines here.
Yes, sir.
So definitely the pulmonary this X-ray was in pulmonary edema. There is hilar bat wing appearance in the lung, haziness, upper lobe veins, interlobar fissure, and curly lines.
Yes.
So with now that tells me that the heart failure left heart. How do you identify right heart failure in X-ray? One is right atrial
Mm.
enlargement. What else?
Uh, effusions can be there, sir. Pleural
Effusion.
effusion.
It is not there.
Uh,
Look at the right
uh,
upper cardiac border. What do you see there?
yeah. Dilated SVC.
Yes, please. Look at the SVC is straight and
Yes, sir.
and you yourself said it's a very well centered X-ray. You gave it a
Yes, sir.
certificate, isn't it?
Yes,
So
sir.
you can see that the SVC is well outside the mediastinum.
Yes, sir.
Yes.
Yes.
So I think you have very clear evidence of failure on both sides of the heart. Increase pulmonary venous pressure, increase systemic venous pressure. But the surprising thing is the heart size is not enlarged. Agreed?
Yes, sir.
Yeah, okay. So if I were to give a complete description of this X-ray, it would be this. Well, the X-ray was initially reported as, the radiologist description of only patchy non-homogeneous opacities in both right and mid and right lower zone. Now the radiologist is at a disadvantage because he doesn't know the clinical picture. Once you know that the patient has evidence of possible biventricular failure, your eyes are much more sharper than even the radiologist. Now, with that history and physical science in your mind, I can read this X-ray better than that radiologist report. I think both right atrium is definitely enlarged. LA left atrium enlargement is possible, but then the bronchial splaying is not so convincing. Bilateral batwing appearance, haziness, fuzzy vascular margin. There is a prominent interlobar fissure on the right side. Increased upper lobe veins, curly B line, straightening and prominence of the SVC, indicating both right heart failure, confirming your clinical diagnosis of heart failure. And again confirming that the heart size is not increased. Agreed?
Yes, sir.
Yes. So now you have come to the end of your clinical judgment in the OPD. Now before asking echo, you got to put down a diagnosis because you have to tell
Yes,
the
sir.
echocardiographer what to look for.
Yes, sir. So, sir, history of heart failure along with pulmonary venous hypertension leading to pulmonary arterial hypertension leading to right-sided heart failure. Mostly possibility of as there is no cardiomegaly, so left-sided regurgitated lesions are ruled out. So it can be mitral valve inflow, like diseases like mitral stenosis or pulmonary vein obstruction or
mitral stenosis with no murmur in a
yes,
child?
not possible, sir. Yes, sir. So
Of
pulmonary
course, rare causes
yes,
of pulmonary vein stenosis is
stenosis.
possible. I agree with you. Yes. What else?
Some condition which is leading to LV
But you see,
diast.
remember, mitral stenosis will not, pulmonary vein stenosis and mitral stenosis will not cause left ventricular voltages to be increased.
Yes, sir. It can be left ventricular diastolic failing leading to pulmonary venous.
Okay.
Like conditions like hypertrophic cardiomyopathy.
Yes, hypertrophic cardiomyopathy, restrictive cardiomyopathy.
Myopathy, yes, sir.
Yes,
Or
possible.
constrictive pericarditis.
Constrictive pericarditis. So we have to keep in mind something which doesn't produce loud murmurs. Yes?
Yes, sir.
Okay. Now I'll give you the echo one by one. Now I hope you can see the video playback. Have a look. Okay. I'll give you 10-15 seconds on each video. Are you able to see? Give me a commentary of what you see. Situs
Yes, sir.
solitus in the first one. Forget the first one. Okay.
Yes, sir. So the IVC in second one we can see dilated IVC, which is collapsible,
Okay.
and
some reflux in the
flow.
hepatic
Yes,
veins. Okay.
yes, flow reversals are there.
Okay. Ignore the. Okay. Quickly go. There are two of them there. Can you see both? Both are
Yes,
playing
sir.
normally.
Yes, both are playing, sir.
Yeah. What do you
So intact IS, interatrial septum is intact. SVC flows are uninterrupted, and no effusions are there. The left ventricular wall looks hypertrophied, sir.
We'll look at the left ventricle later. No, this
Okay,
image is concentrating on the atrium. What do you think of the atrium?
It is dilated, sir.
Yeah. So why didn't you say that? Which atrium
Both
is
the
that?
both of
Yeah.
them looks dilated. Both of
Yes.
them are dilated.
Both the atria are dilated. Definitely.
Yes, sir.
Yes. So okay. So And there's no significant leak in the mitral, as far as we can see, there's no leak. We'll come to that later again, okay?
Yes.
Okay, long axis and apical four-chamber view.
So there are no mild mitral regurgitation is there. Dilated.
Come on, I don't think that amount of degree regurgitation
Yes.
is physiological. Don't
Yes,
think, no.
dilated both atria and both atria are usually dilated, sir, and ventricles are of normal size, and there is no aortic no outflow obstruction, left ventricular and
What is the most striking thing which you see here?
so the
You're
atria are
not, you're
disproportionate.
not having ventricular function at all. This is such an important part of heart failure.
Yes, sir.
Ventricular function?
Functions looks okay, sir.
That's why are you so afraid to say that? Say that.
Yes, yes, it looks
Right.
normal.
Left ventricular systolic function appears
Looks
to be normal. Why
yes,
are
sir.
you so hesitant? Okay.
Yes, sir.
So so you said outflows normal, inflows normal, and there is no major leak anywhere.
Yes, sir.
Okay. So now what? What do you want to do next?
I would like to get a inflow gradient across mitral valves to see diastolic dysfunction.
Okay. You
And M mode across to see the left ventricular wall thickness and
okay. So you want to see left ventricular measurements, and you want to see the pulse Doppler across the mitral valve. That's what you want to see, is it?
yes, sir.
Okay. So that's your left ventricular measurements. Ejection fraction of 58%.
Yes, sir.
Okay.
Yes, sir.
Right ventricle
Nothing.
not dilated. LV is also not dilated.
Yes.
Okay. Wall thickness,
No.
interventricular septum about 6 millimeters, which is possibly for a 4-year-old child borderline increase. Both posterior wall and the interventricular septum are by 6 millimeters. Okay.
Yes, sir.
Right. So that's your pulse Doppler across the mitral valve.
Yes.
I've given you the values at the bottom.
E by 0.72, sir. The diastolic dysfunction is there. And
Anything else? Some other values are given there. E wave, A wave. Yeah. What is EDT?
I don't know, sir.
Diastolic deceleration time, no? Deceleration time of the mitral inflow from E point to the baseline. Just no? Can you see my arrow there? From
Yes,
here to here. That the time taken for the peak E velocity to fall to 0, deceleration time, to 254 milliseconds. Yes, agreed. A wave is somewhat taller than E wave, indicating grade 1 uh, diastolic dysfunction, but that's very non-specific. But there's something else which is very important. Is the diastolic deceleration time is 254 milliseconds, which normally have you seen a E wave? How does it appear?
But it is not so wide.
It's not so wide. Why is it not so
Yes.
wide?
Um,
You're right. Very good. You're
yes,
you're doing very well.
because it is because of the gradient across.
No, there's no gradient. There's no gradient. The velocity is less than 0.5 meters. There's no gradient. The deceleration is very sharp, very fast in the normal valve. With the normal myocardium and the normal mitral valve, the deceleration time is very short. Therefore, you see a sharp upstroke and a sharp downstroke. Now, somewhat like a EF slope. You familiar with EF slope in M mode?
No, sir.
Huh?
Yes, no, sir.
Yes or no?
No, sir.
You don't know what is EF slope in M mode? M mode echo? M mode of the mitral valve?
No, sir.
Well, then you should go and read.
Yes, sir, I'll read it.
The AML forms an M pattern, isn't it?
Yes, sir.
So from the peak of the E to the to the to the onset of A is a downward slope, isn't it? Normally it is
Yes,
sharp downwards.
yes, sir.
In mitral stenosis, it becomes horizontal.
Hmm.
Yes?
Yes, sir.
Okay, that is in M mode. In pulse
Okay.
Doppler, it is the equivalent of that is the deceleration slope. This slope, okay? This
Yes, sir.
determines the rate at which the ventricle is filling in the rapid filling phase, early diastolic filling. Agreed?
Yes, sir.
When it becomes more horizontal, when the deceleration time is increased, it means that either the mitral valve is obstructed or the left ventricular relaxation is impaired.
Yes, sir.
Left ventricle is taking longer to relax. Agreed?
Yes, sir.
Okay. So here we have clearly no obstruction in the mitral valve. We saw the mitral valve moving.
Yes, sir.
Therefore, increased deceleration time is a sign of impaired myocardial ventricular relaxation.
Yes, sir.
Another sign of diastolic dysfunction. Yes or no?
Yes, sir.
Yes. Okay. Gone. Next, what do you want to do?
Mm.
I think we have to move a little faster because I got a
Mm.
lot more slide. I want a lot more discussion to do. Okay, let me go on to this.
So,
So that is
how?
the echocardiographic report. Huh?
Yes, sir.
You told me most of the features except that you had a little hiccup in the pulse Doppler, the mitral valve. You should go back and read mitral valve
Yes,
M
sir.
mode echo. You should read mitral valve Doppler and deceleration times. All the indices related to diastolic function you must read again.
Yes,
Okay,
sir.
marked enlargement of both the atria. LV wall thickness not clearly increased, but there's no normal outflow, normal systolic function. Clear evidence of diastolic dysfunction in delayed relaxation and in a prominent E wave. The IVC is somewhat distended, and the RV systolic pressure was 32 plus RA pressure, therefore not clearly increased, maybe mildly increased. Effusion, they have reported it as mild, but I didn't think there was any effusion. Okay, so that
Yes,
is
sir.
the echo report. More or less, we got all of it. So let's go on to the next one. Do you want anything? Do you want to look for any more features?
So, how is the pericardium?
Pericardium, okay. Pericardial effusion, they reported trivial, but there was no pericardial thickening. What else?
And
Remember,
how pulmonary vein flow? How is it?
normal. Okay,
How
now
is
you
the
go
septal movement?
septal septal movement. You mean
Yes, sir.
septal movement was occurring with the left ventricle. It was not bowing into the left ventricle. That what you wanted,
Yes, sir.
or anything else?
Okay.
Oh, I was hoping you'll ask something else, but you didn't ask. Okay,
Strain echo was done or not, sir?
I'll show you. Okay, I'll tell
Yes,
you
sir.
the strain echo, but before that, I go to strain echo. Uh, Remember, he had a eosinophilia in the history, and he had some atopic dermatitis and all
Yes,
that.
sir.
I told you to keep it in the back of your mind. So whenever somebody presents with diastolic heart failure and a history of eosinophilia, you have to think of eosinophilic heart disease. So always look for endocardial thickening, cavity obliteration, any valvular thickening, thrombus in the ventricle, thrombus in the atrium, or restrictive heart disease. There could be amyloidosis, there could be sarcoidosis, so many things. You have to look for thickening of the intraatrial septum, thickening of the myocardial texture. Now, all these are findings which you should specifically look for. Now, these features were not present in this case, but when I asked you what other things would you look for, A good student should answer these things, because particularly because this boy gave you history of eosinophilia,
Yes, sir.
right? There
Yes,
was
sir.
no endocardial thickening, there was no cavity obliteration, there was no thrombus, there was no valve thickening, there's nothing to suggest any disease such as changes in myocardial texture or thickening of the intraatrial septum, thickening of the valve leaflets and all that. So these are important negative features. If you're a good student, I expect you to tell me all this. Okay?
Yes, sir.
Now I'll show you this one. Okay, that is the TDI of the mitral annulus. Can you do it a little faster, please? Okay, E by E prime ratio. Are you familiar with TDA of mitral valve?
Not so much. I need to read that.
Okay, anybody in the audience is familiar who can tell me a finding? Anybody else who want to volunteer? I think you should read it, because I don't think pediatric cardiology is exempt from reading TDI.
Yes, sir.
You can't say I don't know about it. Okay, let me say, to save time, I would do. Now, E by E prime is distinctly abnormal. In adults, the normal value is cutoff is 15, but in children, the cutoff value is much lower. Now, I don't want a diagnosis. Somebody has written right restrictive cardiomyopathy. I don't want a diagnosis. I want you to interpret this finding, please. Okay. So E by E prime is a guide to the left ventricular filling pressure. Now, I don't have time to tell you the theory of E by E prime. Please go back and read. Okay. Now, the normal range of E bar E prime is 6.5 plus minus 2 for kids. Therefore, E bar E prime of 11.6 is clearly abnormal, indicates that the left ventricular filling pressure or left ventricular end diastolic pressure or LA pressure is very much elevated. Now, the other abnormality you find is that the systolic wave, systolic tissue Doppler velocity is reduced. 5 is quite low. Normally, you would expect it to be more than 7 to 8. So, this is reduced, indicating that there is some problem with the systolic phase of mitral annular excursion. In addition, the E prime is very, very small. E prime is very, very small compared to the A prime. E prime is small, A prime is large, which is again like pulse Doppler across the mitral valve is very suggestive of a diastolic dysfunction of the left ventricle. Now, somebody very correctly pointed out the uh, lateral annulus E prime is less than the medial annulus E prime. Very good. Who was that? Well, it doesn't matter. Whoever said it, very good. Now, normally the lateral mitral annulus E prime and the S wave is always larger, more active than the medial annulus, and that is because the lateral annulus is always more mobile than the medial part of the annulus. And the importance of this finding is that in constrictive pericarditis, very often the lateral annulus gets restricted and the medial annulus starts becoming relatively more mobile than the lateral annulus. That's called annulus reversus. That's what somebody put it up, and I don't know the name of that person, but I appreciate his correct answers. Now, but here it is not clearly reverses because they are more or less equal. S of 5.3 in both, and 3 and 3.6 no, E prime, I think it's a very close value. It's not difference is not big enough. So I wouldn't diagnose annulus reverses in this case. Please go back and read what is annulus reversus also, please. Annulus, write down all these terms that I am talking, annulus reverse. Okay. So overall, the pulse Doppler and tissue Doppler suggest restrictive cardiac physiology, which again confirms your physical examination and echo finding. And therefore, we are now differential diagnosis of restrictive cardiac physiology. This I've already talked to you. Now, of course, I would always, because I'm thinking of excluding constrictive pericarditis, I would like to look for ventricular septal movement. When you ask for septal movement, I thought you would ask for jerky movements also called as, what is it called in jerky movement of pericardium, of the septum in constrictive pericarditis? What
Septal
is it called?
bounce.
Septal bounce. You didn't use the word septal bounce. That's why I was a little unhappy. Never mind. So go back and read all the signs, echo signs of constrictive pericarditis. I'm not saying this boy has constrictive pericarditis. Okay, don't jump to any conclusion. Okay, then I would also look for thickness of the intrahiatal septum and strain rate for speckle training and also all the newer gadgets. Okay, could it be constrictive pericarditis? Clinical findings and ECG, yes, possible. But ECG is unusual because it shows left ventricular hypertrophy. Very unusual in constrictive pericarditis to have high voltages. Secondly, there is no septal bounce in this case. There is no respiratory variation. When I showed you the echo finding, I didn't tell you about any respiratory variation. And E by A ratio is 0.7. What's the classical pattern in constrictive pericarditis? In constrictive pericarditis, almost all the filling takes place in the early diastole, and there is no filling in late diastole. The A wave is very small, only the E wave is prominent. That's the restrictive pattern of constrictive pericarditis. Whereas here you have a large A wave, which means most of the filling is occurring in the late diastole. Agreed?
Yes.
So this is totally against constrictive pericarditis. You get my point? Everybody understand that? There is no respiratory variation. The A wave is prominent. A wave prominent is against constrictive pericarditis. There is no septal bounce. There's marked reduction of S velocities and E prime velocities in the mitral annular tissue Doppler. Both are against constrictive pericarditis. Constrictive pericarditis, the annular velocities remain normal. And as I told you, okay, annular production we won't talk about them. Moreover, constrictive pericarditis is a very chronic condition. No? It doesn't give usually a short history, but of course, it can only be a short presentation, so that is not a very important point. So to me, it looks constrictive pericarditis unlikely. Also, the X-ray did not show any what? Calcification. Okay, calcification, of course, you need some lateral view or a fluoroscopy to be 100% certain. But in a child, if there is calcification, you should be able to see it on a chest X-ray in the frontal view. Okay, a quick examination, mild elevation of eosinophils, an absolute eosinophil count of 1365. Okay, not very high. And some increase in the TSH level, 9.8. Well, that's very mild increase in TSH. I wouldn't diagnose hypothyroidism based on one single value of 9.8. Now, I have encircled a number of these values. Please remember these values. I'll come back to this while I'm discussing the diagnosis. Okay? Transferrin and serum ferritin, both are normal. I have encircled a normal value. Of course, as I expected, NT-proBNP is elevated. Okay? Now let's go on now because we're running out of time. So now we have problem description number 3. Restrictive cardiomyopathy, eosinophilia, some hyperimmunoglobulinemia, good biventricular systolic function, cardiac failure controlled on diuretic, no significant PA, sinus rhythm, possibly mild hypothyroidism but not very convincing. Now, what is the cause of this restrictive cardiomyopathy? Now, I'll go across this. Now, let's look at this X-ray again. We thought it was pulmonary edema. Now, could it be eosinophilic lung? Now, just to differentiate between eosinophilic lung and pulmonary edema lung, I've shown an X-ray which shows eosinophilic lung from a publication. Okay, both of them superficially they look similar. Both have similar heart size. Both look congested in the lung, but there are important differences. Now, but the important differences are here. There is distinctly the interlobar fissures, curly line, upper lobe veins are very suggestive, and atrial enlargement are very suggestive of heart failure. Here you do not have interlobar fissures. You do not have upper lobe vein. You only have diffuse mottling in the lung fields. Okay, And what is against eosinophilic pneumonia is an absolute eosinophil count of less than 1500 does not qualify for eosinophilic disease. No? You need to have a high absolute eosinophil count of at least 1500 to cause eosinophilic heart disease. Eosinophilia is very common, but eosinophilic heart disease is very, very rare. X-ray CT findings are not specific. And interestingly, in this patient, the X-ray taken after diuretics, the lung findings improved. Can you see only the right atrial enlargement and the left atrial enlargement remaining, and the pulmonary edema has disappeared. And therefore, this is unlikely to be eosinophilic lung. We can straight away rule it out. We'll ignore this. So therefore, eosinophilia is probably unrelated. Thyroid is probably unrelated. So what is the type of restrictive heart disease we are facing? So I'll make it easier. The various causes of restrictive heart failure can be divided into idiopathic, infiltrative, scarring, and storage disorders. Four broad groups: idiopathic, infiltrative, scarring, and storage disorders. Now we have to go one by one to find out what it is. Idiopathic, of course, is the last. It's a question of ruling out all the others. Okay, we'll leave that for the last. Right. Now I think we can straight away rule out scarring because we did not have any evidence of enough evidence of important absolute eosinophilia. We do not have any evidence of cavity obliteration. We do not have cavity obliteration in the right ventricle or left ventricle. We do not have endocardial scarring. We have no other causes of scarring like surgery, radiation, anti-neoplastic drugs, and we don't have any systemic diseases in the form of scleroderma. The scleroderma is a disease of adults, therefore I would not talk much about it. But we do not have other causes of endomyocardial scarring. So I think we can straight away rule out that condition. So that leaves us with infiltrative diseases and storage diseases. Let's go one by one. Can it be amyloidosis? Now there are different types of amyloidosis. AL is a primary amyloidosis, occurs mainly in elderly people, often associated with plasma cell dyscrasias. So that question doesn't arise. Secondary amyloidosis commonly occurs in people who have chronic inflammatory disease, lung abscess, osteomyelitis, and so on. Again, it's more common in adults, not common in children, and we have no sign of any chronic inflammatory disease. Hereditary amyloidosis is an autosomal dominant. We do not have evidence here. And almost always there is extracardiac features are very prominent, like neuropathy, visceral enlargement, hepatosplenomegaly. Those are prominent features. We do not have evidence of hereditary amyloidosis. So I think, and the fourth form is senile amyloidosis. I don't think this boy fits into any of these features. And moreover, we do not have any extracardiac features. No gastrointestinal involvement, no proteinuria, no dysphagia, no large enlargement of the tongue, no joint symptoms, sensory symptoms, voice change, carpal tunnel, visceromegaly, nothing. Voltages in amyloidosis typically low voltages. Here we have high voltages. Echo should show thickening of the septum, changed appearance, that should more granular appearance of the myocardium. Intraatrial septum and valve should appear thicker. Again, all these features are missing in this case. So amyloidosis is, I would cut it out. Can it be sarcoidosis? Sarcoidosis again is a disease of adults. It's a multisystemic disease. More importantly, it affects lungs, hilar lymphadenopathy. Incidentally, we did a CT scan. There was no mediastinal abnormality in this case. Commonly present with systolic and diastolic dysfunction. And they have arrhythmias, conduction defect or tachyarrhythmia. No lymphadenopathy. There's evidence of scarring in CMR and systolic functional abnormalities. Again, none of these features were present in this case. I would cut out sarcoidosis. Hemochromatosis, again unlikely. His appearance was normal. There was no skin pigmentation. There was no hepatosplenomegaly. There was no diabetes or hepatic dysfunction. The heart is affected only about 20% of hemochromatosis, and generally the wall thickness is markedly increased. Generally, the iron values are abnormal in hemochromatosis. Transferrin would be elevated, ferritin would be elevated. And you remember in the blood test, I told you that transferrin and ferritin are normal. But again, in the examination, you won't have transferrin and ferritin value in your hand. Therefore, clinically, this features face color, skin color, hepatosplenomegaly, and the type of heart failure, only diastolic heart failure without systolic involvement, without thickening of the walls, is against hemochromatosis. What is against in storage disorders? Storage disorders, again, it's a multi-system disease, always multi-system, always multiple organs are involved, and therefore, if you have heart alone as a involvement, storage disorders are unlikely. You should have some evidence of visceromegaly, neurological involvement, kidney, liver, some other organ to be involved, and always it's also commonly a systolo-diastolic involvement. Okay. So, storage disorders as an isolated diastolic heart failure is quite unlikely. And if you remember the echo, the myocardium appeared normal. It didn't appear granular or hyperechoic. Therefore, storage disorders are very unlikely. So, now what are you left with? You are left with the topmost category of idiopathic heart failure. At least that's your clinical diagnosis. Yes? So now we are left with idiopathic restrictive cardiomyopathy, mild unrelated dermatitis and mild eosinophilia, good biventricular systolic function, symptoms controlled on diuretics, and mild hypothyroidism, only a biochemical diagnosis. I'm not sure if this clinically significant. Now, by the way, hypothyroidism and hyperthyroidism both can cause cardiomyopathies, but then not this degree of thyroid involvement and not this duration of thyroid involvement. Okay, so that is our problem description number 5 at the end of clinical ECG, X-ray, echo, and blood tests. Now that's our problem description number 5, and that is where we arrive at a diagnosis. Of course, you can do many more investigation, cardiac MRI, cardiac catheterization, biopsy, genetic screening, and so on to arrive at a diagnosis, but that's where we land at the end of examination. Now I have catheter data here, which essentially shows features of high EDP and mildly elevated PA pressure. And in the interest of time, I won't go into the details of cath. I will. Now, just to give you a little bit of theory, idiopathic diastolic dysfunction, idiopathic restrictive cardiomyopathy, uh, they are of different types, commonly inherited or mutation. And there are 3 predominant type of sarcomeric mutations or filament C and desmin. I don't expect you to remember all this, but I'm just telling it to you for interest. If you're interested, you can go back and read about it. And therefore, this would require more detailed evaluation by tissue typing and gene analysis and myocardial biopsy. And myosin chain abnormality is often the most common variety. Most common one, which affects selectively the heart, the filament C is a relatively late, and the desmin mutations often affect both skeletal and the cardiac muscle. And therefore, this seems unlikely. In this case, most likely, it must be one of those myosin binding chain abnormalities. Now, that's a guesswork, and I don't have proof of that. Okay. Now, what is the expected course? This you must answer, Kashmira. Are you there? I hope
Yes,
you
sir.
haven't fallen asleep.
No, sir.
No, I'm sorry, I'm joking. Come on. So, what's the expected course?
The child should be treated with diuretics and.
Well, that we are already doing.
So, it has a bad prognosis and
Yeah, good.
irreversible.
Yes,
And
it's unfortunately it has a very poor prognosis. Most inherited forms of restrictive cardiomyopathy or idiopathic cardiomyopathy have a dismal outcome. Their long-term survival is not good. Temporary improvement in symptoms and functional class are stable, but there is unfortunately no permanent improvement or cure to be expected. Therefore, a downhill course is to be expected, because that's important for uh, counseling the parents. Now, what are the potential causes of death? One, of course, is the huge atrium and high LA pressure, thromboembolic, quite common, pulmonary thromboembolism, coronary thromboembolism. Arrhythmias can occur, worsening heart failure, especially pulmonary edema, and of course, um, because of abnormal myocardial filament function, often coronary ischemia is often one cause of death, not because the coronary arteries are abnormal, but because the myocardium is abnormal, the intramyocardial, because the high filling pressure, the myocardial perfusion is very much impaired. Therefore, there is ischemia at the cellular level, and myocardial perfusion is often quite abnormal, and sudden cardiac death is quite common. So, the prognosis is quite poor in these cases. Therefore, it's important to know what type of restrictive cardiomyopathy it is, by which you can counsel the parent for future, also to counsel the parents regarding the management of this case, which invariably would be downhill, and possibly the only viable option is cardiac transplant. Okay, now that's all I have to present, and that's already 6 o'clock. But I would be happy to answer any questions if there are any. I skipped the cardiac catheterization because we are short of time, but that doesn't matter because it more or less confirmed what I told you. The only important thing I would like to point out in the cardiac cath, it did not have any features of constriction. That is, there was no equalization of diastolic pressure in the LV and RV. The LVEDP was much higher than the RVEDP. The LA pressure was much higher than the RA pressure, and although the diastolic waveform in both RV and LV had a square root pattern. The square root pattern can happen in both um, restrictive cardiomyopathy as well as constrictive pericarditis. Okay. Now, there are a lot more differences, hemodynamic differences between constrictive pericarditis and restrictive cardiomyopathy. But I think that will take a whole 1 hour lecture. So that we'll discuss some other time. Approach to restrictive physiology and cardiac catheterization. Right. Any questions?